Welcome to the deep dive. Today, we're tackling a really big one, osteoarthritis, specifically knee and hip OA, which is just incredibly common worldwide.
Absolutely. We're talking hundreds of millions affected.
Mm.
And it's not just the pain and stiffness, it's the impact on, daily life. Quality of life really suffers.
And the typical go-to treatments, well, they come with baggage, right?
They do, those standard anti-inflammatories, the NSAIDs. I mean, they can help with pain, but long term, you're looking at potential gut problems, serious cardiovascular risks. It's a real concern.
So the search is on for safer alternatives. We know exercise helps, resistance training specifically. But the big question has always been, how much?
Exactly. Dosage. That's been the missing piece. Lots of studies showed RT works, yeah, but not how much is needed. Is more always better? Or less?
Which brings us to this deep dive. We're looking at a major review, a dose-response meta-analysis.
That's right. 28 randomized trials, over 2,000 people. They really set out to find that Goldilocks zone for pain relief with RT.
Okay, so give us the headline finding. What jumped out?
Well, the most, I think, surprising thing is that it's not linear. The relationship between how much resistance training you do and how much pain relief you get, it's U-shaped.
U-shaped. Okay, what does that mean practically?
It means there's a sweet spot, do too little, and, well, you don't get much benefit. But interestingly, do too much, and the benefit actually starts to decrease again. You might irritate the joint or overdo it.
So not just move more, it's move the right amount.
Precisely. Too little or too much, both are less effective than hitting that optimal dose.
Okay, before we get to the dose itself, let's just confirm the basics. Does resistance training definitely help with OA pain?
Oh, absolutely. The overall analysis confirmed it clearly. Compared to control groups doing no exercise, RT significantly reduced pain.
How significant are we talking?
They used a measure called Hedges G. It came in at minus 0.57. Which, statistically and clinically, that's considered a moderate effect size.
Moderate effect. So noticeable improvement for the average person.
Yes. Enough that people would likely say, yeah, this is making a real difference in my day-to-day pain. It's meaningful.
And is it just a temporary fix while you're doing the exercises?
That's another key finding. No, it seems quite durable. The study found pain improvements were maintained for up to 6 months after the participants stopped the specific training program.
6 months? Wow.
Yeah, it suggests the changes happening are more than just temporary. There's some lasting, medium-term relief baked in.
Okay, so it works and it lasts. But why? Loading a joint that already hurts? It feels a bit counterintuitive.
It does, doesn't it? But the body's pretty amazing at adapting. There are several things going on.
Like what?
Okay, first, the most obvious one is biomechanical. You strengthen the muscles around the joint, think your quads, your glutes.
Right.
That provides better support. It acts like a better shock absorber, taking some load off the actual cartilage.
Building a stronger scaffolding, basically.
Exactly. A better suspension system, that's one. Second, there are systemic physiological effects.
Systemic, meaning body-wide?
Yeah. Structured exercise seems to have an anti-inflammatory effect. It can actually lower the levels of some of those inflammatory chemicals, cytokines like TNF-alpha and IL-6, that circulate in your body and contribute to OA pain and progression.
So strength training isn't just local muscle stuff. It's affecting inflammation levels throughout the body.
Seems like it. And then the third mechanism is maybe the most interesting. It's about pain processing.
In the brain.
In the brain and nervous system, yeah. It's this concept called exercise-induced hypoalgesia. Basically, doing the resistance training seems to activate your body's own built-in pain relief systems.
Like endorphins.
Endorphins, yes, but also other non-opioid pathways. It essentially turns up your pain threshold. Your brain becomes less sensitive to the pain signals coming from the joint.
So you're strengthening the joint support, reducing inflammation systemically, and retraining how your brain responds to pain. That's quite a combo.
It really is. It explains why it can be so effective.
Okay, let's get back to that crucial U-shaped curve, the dose. How do they measure the amount of exercise?
They use a standard unit, MET per minute per week, MITs and min week.
METs. Remind us what that stands for.
Metabolic equivalent of task. 1 MIT is just your resting energy expenditure, like sitting quietly. An activity might be 3 MIT-Ts, 5 MIT-Ts, meaning it takes 3 or 5 times the energy of resting.
Okay.
So METs min weight combines the intensity, MIT-Ts, and the duration MIT into one single number representing the total weekly training volume. It lets you compare, say, a short, intense session with a longer, easier one.
Got it. So using that mid-tees min-week metric,
Right.
what are the key numbers from this U curve we need to know? Where does the benefit start, peak, and fall off?
Right. So first, the minimum effective dose. To get a clinically important difference in pain, or they call the MCID, you need to be doing around 280 min-tees min-week.
Below that is probably not doing much therapeutically.
Likely not enough for significant pain relief, yeah? More like maintenance. Then there's the sweet spot, the optimal dose.
Bottom of the U.
Exactly. The point of maximum pain relief. That was found to be 680 METs min-week. That's where the effect size was largest. Hedges is A of minus 0.73.
680 METs min-week. Okay. And where does it start to become too much? The upward swing of the U.
The benefit noticeably diminished when the dose went above 1100 on 80 METs min-week.
Why would more become less effective?
The thinking is at that point you might be causing too much joint irritation, maybe triggering more inflammation, or just general overtraining effects that counteract the benefit.
This is huge. It moves us from just saying, do some strength training, to having a specific target.
It really does. It gives clinicians and patients a concrete goal, and for public health, it allows designing programs aiming for a specific effective dose.
Now, did everyone respond the same way, or did certain factors influence how well this worked?
Yeah, this is where it gets really interesting. They looked at moderating factors, and one big one was sex.
House.
With a higher percentage of female participants actually showed a greater pain-relieving effect from the resistance training.
Women benefited more. Why might that be?
Well, there are a few theories. Hormones could play a role. Estrogen has some protective effects on cartilage. Biomechanics might differ, like the Q angle at the knee. Maybe RT helps stabilize that particularly well in women. And we also know there are some sex differences in how pain signals are processed centrally in the brain and nervous system. So maybe that exercise-induced hypoalgesia effect is just more potent.
Fascinating. What about age? Did that make a difference?
It did, but in the other direction. The benefits were less pronounced in studies focusing on older adults.
So older people didn't respond as well. Why not?
Two likely culprits related to aging. One is called anabolic resistance, meaning their muscles don't build protein, don't adapt, and get stronger quite as efficiently in response to the same exercise stimulus compared to younger people.
They get less bang for their buck, exercise-wise.
Sort of, yeah. And the other factor is inflammaging. It's this low-grade chronic inflammation that tends to increase with age. That background inflammation might sort of dampen the anti-inflammatory benefits of the exercise and maybe hinder recovery.
So older adults still benefit, but maybe the dose needs tweaking or the expectations adjusted.
Exactly. Individualization becomes even more important.
Okay, sex and age matter. What about weight? Did baseline BMI influence the results? We often think higher weight equals more joint stress.
You'd think so, wouldn't you? But surprisingly, no. Baseline BMI did not significantly affect how well RT reduced pain.
Really? Why not?
It suggests the positive effects of RT. The muscle strengthening, the better joint stability. Maybe those systemic anti-inflammatory effects are powerful enough to provide benefit even in people with higher body weight. The strengthening seems to overcome the load factor, at least in terms of pain relief.
That's actually really encouraging. It means this can work regardless of where someone's starting weight is.
It's a very positive message, removes a potential barrier.
One more factor.
Right.
Did it matter how the training was delivered? Supervised versus unsupervised?
Yes, that seemed quite important. The analysis suggested that the benefits of unsupervised resistance training were not statistically significant or reliable.
So just giving someone a sheet of exercises might not cut it.
It seems less likely to be effective, yes. Having supervision likely helps with proper form, progression, and crucially, adherence, making sure people actually do the exercises and hit that necessary volume, that optimal dose.
Right, getting them to that 680 METs min-week target. Okay, let's make that practical. How does someone actually hit 680 METs min-week? Can you give us some examples?
Sure. Let's use the MET values from the paper's examples. If you're doing pretty vigorous free weight training complex lifts, higher intensity, maybe around 6.0 METs.
Okay.
To hit 680, you'd need about 113 minutes per WINT, so maybe 2 solid 60-minute sessions.
Right, 2 hours a week of serious lifting. What if it's a bit less intense, say controlled squats, deadlifts, maybe some machine work, averaging around 5.0 METs?
Then you'd need a bit more time, around 136 minutes a week. That could be, say, 3 45-minute sessions.
Okay, still manageable. And for beginners, maybe doing mostly bodyweight exercises, general conditioning, perhaps around 3.0 METs.
Then the time commitment goes up. You'd need roughly 226 minutes per week to reach that 680 target.
So closer to 4 hours a week, maybe 4 55 or 60-minute sessions.
Exactly. It really shows that trade-off between intensity and duration to get the required total volume, that stimulus.
This is incredibly useful, having concrete targets. But we need to be critical of the research itself, right? How strong was the underlying evidence in this meta-analysis?
That's crucial, yes. And it's a major caveat here. The researchers rated the overall quality of the included evidence as low.
Low. Only 4 of the 28 trials were considered low risk of bias.
That's right. That's not ideal. It means many of the studies had methodological weaknesses that could affect the results.
And they also found publication bias.
Yes, significant publication bias was detected, which suggests that smaller studies that maybe didn't find a strong positive effect might be missing from the published literature.
Okay, so low quality evidence, potential publication bias. How much faith should we really put in that specific 680 AMETs min-week number? Does this make it more of a guideline than a hard rule?
I think that's exactly the right way to look at it. The shape of the dose response, that U-curve, seems pretty robust across the data. There clearly seems to be an optimal range.
Right.
But the precise numbers, the 280, 680, 1180, they might shift a bit as we get more higher quality research without that bias. So yes, treat 680 as the best current estimate, a strong guiding principle for clinical practice, but acknowledge the uncertainty.
So the takeaway isn't necessarily exactly 680, but that there is an optimal intermediate dose we should aim for. Enough to be effective, but not so much it backfires.
Precisely. It strongly justifies aiming for that intermediate volume around that 680 mark while knowing we need better studies to nail it down further.
Okay, so wrapping this up, what's the core message for our listeners dealing with knee or hip OA?
The message is hopeful, and it's specific. Resistance training works. It provides moderate, durable pain relief. And we now have a much clearer idea of the dose needed. Aiming for around 680 METs min-week seems optimal based on current evidence.
But individualization is key.
Absolutely. Consider age. Older adults might need adjustments. Supervision seems really important for actually hitting that target dose effectively and safely.
It gives a clear, evidence-based path for non-drug pain management.
It really does. And think about that durability, 6 months of benefit after stopping. This leads to a bigger question, I think.
What's that?
Given we have this evidence for an optimal durable dose, how can we systematically implement this? How can healthcare systems, community programs, physiotherapy services actually deliver standardized RT programs designed to hit that 680 METs min-week target, if we could do that effectively at scale?
We could potentially make a huge dent in OA pain, reduce reliance on medications with side effects, and lower the overall burden of the condition.
Exactly. Moving from just knowing the dose to actually delivering that optimal dose consistently, that feels like the critical next step for public health.